scenario of high pressure injection injuries. You have been called in an A&E. 28 years old, right hand dominant, presented with a left hand injury. He was operating on high pressure paint gun and tried to clean the nozzle with his free hand during the operating the equipment. He wiped the jet, opening a high pressure gun into his left index finger when the gun discharged into his palm, producing pressure of 5000 psi. The paint stream struck the palm with such a pressure that liquid penetrated the skin and spread widely throughout the underlying facial planes and tendon sheaths. To assess the severity of the injury, the type of injecting material and the time of injection was determined. Circulation surrounding the injury was assessed by observing the general skin condition and temperature and capillary fill. To confirm dual circulation of the hand and fingers, a digital Allen test was performed. Anterior forearm part was evaluated with passive wrist and finger extension. Distension of the tissue and the resulting inflammatory reaction caused marked ischemia in the tissue. Treatment was not delayed to avoid tissue necrosis, fever, and leukocytosis. Differential diagnosis: a puncture wound or bites can be differentials. In this scenario, a high pressure injection injury to the palm had happened. The index finger is the most frequently injured digit, followed by palm and the long finger. If the patient delays treatment, the digit may appear erythematous or cold. Edema and intense pain may develop, and loss of digit is ensured. Injuries of the digit are often associated with morbidity than those of the hand because of the potential of developing compartmental syndrome. The severity of the injury is first diagnosed by the type of fluid. Injection injuries with grease guns result in ischemia and chemical irritation, but inflammation is less severe than with the paint injuries. The highest risk of early tissue necrosis and gangrene are seen with paints, paint solvents, and paint thinners. Other fluids such as grease, oil, and mechanical fluids may cause no reaction until 48 hours or further following the injection. However, fibrosis, oligogranuloma formation, and draining sinuses may also occur. The amount of fluid injected determines the degree of vascular compression. Larger volumes, larger vascular compromise. If the fluid was at high pressure, the result in an extension of the fluid penetration, and this may result in large area of spread of injecting material. Timely diagnosis and treatment are the most important factors, as risk of amputation increases at the time of injury to treatment increases. Regarding non-surgical management, prophylactic broad-spectrum antibiotics should be advised, tetanus prophylaxis should be updated, analgesics should be provided, splintage and elevation should be done. Patients should be referred to emergency hand specialist for surgical intervention. Depending on the severity of the compression, injection and clean air or water can be managed conservatively with caution. Regarding surgical management, most high pressure injections in injuries require surgical debridement because of extreme tissue toxicity. Surgical debridement optimizes the tissue salvageability. Debridement may include opening the fingers along non-pinch, non-protective border surfaces. The distended tissues are opened through a large incisions. Longitudinal incision can be made over the injection site to ensure a widespread opening. Alternative approaches may be required. A dorsal thumb space incision may be used to debride the thinner space, and an alternative volar approach can be also utilized. A mid-palmar space is opened with a mid-palmar incision which may be extended proximally to include the carpal tunnel. With paint injury, all paint must be immediately removed from the wound tissue and digital arteries. In most cases, wounds are left open for serial debridement. Early amputation may be considered with severe paint injuries. Antibiotics are given postoperatively and the hand is immobilized and elevated. Amputation rate is around 15 to 50%. Postoperatively, most patients return to the operating room again to undergo open packing. Patient may use whirlpool therapy. Supportive wound care should be provided by a certified occupational therapist.